welcome to clinicalpath.com. Today's lecture is on chronic obstructive pulmonary disease and bronchiectasis. Chronic obstructive pulmonary disease is an extremely common disease and is basically defined as a chronic disease of the airway that is not reversible. So it's not to say that if you give them some short-acting albuterol, there isn't a little bit of improvement. The answer is there's not significant improvement, because that's going to be differentiating it from asthma, which is a reversible disease, and you should see a good response to that entity. When we talk about COPD, we always talk about it as two different patterns of pathology. We talk about emphysema, which is going to be loss of alveolar septi, versus chronic bronchitis, which is clinically defined as cough, but what that tells you is it's a disease of irritation of the airways with mucus production. So we have to divide that into large airway disease and small airway disease because they're different. Let's just set that up as this visual way of thinking about the bronchial tree. So remember, we talk about how many divisions there are. Our first division is into the main stem bronchi, and then we go from divisions 2 to about 7, so that's laryngotracheal main stem bronchi. This then goes into our bronchi, 2 to 7, and then 3 to about 15, these are going to be our non-respiratory bronchioles, and then that's going to take us down from 16 to about 19, and then 20 to about 23. That's our terminal respiratory unit, and that's going to break into our respiratory bronchiole, our alveolar ducts, and then of course our alveolar cells. So when we talk about the structure of each of these, all of this upper airway or large airway disease has in common that it's got cartilaginous rings, and these cartilaginous rings hold the airways open against the collapsing Bernoulli effect of expiration. In addition, they actually have formal glands in their wall, so that the glands are actually secreting mucus in addition to the surface epithelial cells. By comparison, when we talk about the bronchioles, remember these have no cartilage to hold them open, but they do have smooth muscle in the walls. And so this is going to be the area where we see bronchoconstriction in pathology. And then, of course, the terminal respiratory unit, this is where we see our gas exchange. So when we talk about then cigarette smoking and the irritation of it, we're going to see 3 different levels of disease. Here we have our first part down to about level section. This is going to be our large airway disease here, and then our small airway disease here, and then our alveolar wall. So let's take each of those in turn. Let's deal then first and foremost with our large airways. In our large airways, the first thing we're going to see from the irritation of cigarette smoke is that we're going to get a squamous metaplasia. And squamous metaplasia is important because, of course, it's an unstable epithelium that's a risk factor for carcinoma. The irritation is also going to cause glandular hyperplasia, and that's going to be the source of mucus for the productive cough. And then the last thing we're going to see is cigarette smoke actually paralyzes the cilia, so this is going to give us ciliary dyskinesia, and that's going to mean we can't clear our mucus, and that's going to be a predisposing factor to bronchiectasis and recurrent infection. When we come down to the small airways here, now we're going to see a different pathology, because now the pathology is dominated by inflammation. So that's going to give us a narrowing from the edema, but the other thing that matters, of course, is that inflammation can lead to fibrosis. So when we talk about death in bronchial disease, it's this fibrosis that's the problem, and it leads to the so-called bronchiolitis obliterans. So that's quite different than the large airway, which is held open by its cartilaginous ring. Other changes we see in the small airway is we see goblet cell metaplasia, and that's going to give us then more mucus production at that lower level. And then the last things we're going to see then is the inflammation and the fibrosis leading to narrowing. And so this is now, instead of being the physiologic resistance, this is where we see the most physiologic resistance to expiration. Here, that's going to lead to the new focus, which is going to be pathologic resistance at the level of the small airways. When we think about how that works down in the alveolar wall, now we're talking about septal wall loss. And that's going to be very important because that's going to decrease surface area and lead to diffusion defects. The other problem we're going to see higher up is we're going to see loss of radial traction. And remember that radial traction, which we'll talk about more in emphysema, is what holds the small airways open so that they don't collapse. With the loss of radial traction, that's going to lead to the air trapping of emphysema. So the only other pathology image we need to take away there, we've got large airway discussions, we've done a small airway discussion, and then we've done our terminal respiratory unit. The last thing we want to talk about is, well, if you had a patient at autopsy, could you tell if they had chronic bronchitis? And so we talked about the glandular hyperplasia, and that's what we're seeing in this image here. Here we have our pseudostratified ciliated columnar epithelium, and then here's our muscularis mucosa. This then becomes the submucosa, and then here's our muscle layer. And normally these glands, which produce the mucus, which is going to form our mucociliary sheet, these should normally be less than 50% of the thickness here of the entire bronchial wall. But if these glands undergo hyperplasia and get big, we can see they now are more than 50% of the thickness, and that then becomes the anatomical correlate of the glandular hyperplasia we think of in chronic bronchitis, and that's why we are able to produce so much more mucus in response to the irritation. And the pathologist that first described this had a name of Reed, and so therefore that becomes the Reed index, which is measuring for glandular hyperplasia. Okay, well, if we have chronic obstructive pulmonary disease, and you notice we're not really differentiating emphysema and chronic bronchitis, this large airway, small airway, alveolar disease usually are all seen together. We'll divide them out just for purposes of pathophysiology, but no patient ever is a pure one or the other. They're typically going to present with shortness of breath on exertion, and they're going to have a productive cough. So those are sort of your key elements for thinking about it. Shortness of breath on exertion, this is going to have a couple of reasons for it, right? We've decreased the surface area when we lose our alveolar walls, and we're going to get air trapping from the collapse of the small airways from loss of radial traction. Productive cough is going to come from our increased mucus production, and that correlates with our glandular hyperplasia. So that's what the patient complains of, so those are our symptoms. What are you going to see on physical exam? And the answer is not much. You're really not going to have anything positive on the physical exam until very late. And by very late, we're really talking about function typically of loss of more than 80% of typical function, and that's usual for most organ systems. When we talk about what we're going to see then in late disease, we really talk about what we're going to see in emphysema, which is going to be our pink puffer. The reason we see that is, remember, if we talk about emphysema, we lose the entire septal wall. So we have a balanced loss of perfusion to ventilation. So that means there's no desaturated blood, so the patient does not show cyanosis and is pink. However, the balanced loss is correlated to a decrease in surface area, so the patient has to increase their respiratory rate to compensate for the loss of surface area to regain oxygen. When we talk about chronic bronchitis, again now we're talking about late enough disease that we're starting to get VQ mismatching. Remember, this is a disease with obstruction of the bronchioles. So we're going to have perfusion of non-ventilated areas, and that's going to lead to cyanosis. So these are called blue because we see that desaturation from the VQ mismatching. And then the blue bloater part of their discussion is because once I start getting that hypoxia, I start getting increase in pulmonary artery hypertension that leads to cor pulmonale. And cor pulmonale leads to right ventricular heart failure, and that then gives me the edema for the bloater. So when we talk about this spectrum of change in COPD, we go from a pure emphysema representation of pink puffer versus the chronic bronchitis ventilatory spectrum of the disease, which is our blue bloater. And that's a good way to think about late-stage diseases and how they're going to present pathologically. Well, so what are we going to do when we're testing? Remember what our 3 ways of testing in lung are going to be. They're going to be pulmonary function testing. They are going to be arterial blood gases or pulse oximetry in the outpatient screening setting. And the last is going to be imaging. Let's call that chest x-ray. But everyday office outpatient care, pulmonary function testing is very easy to do. And so we're going to talk about the spirometry. So this is an obstructive lesion, so it's an obstructive pattern, which means that our FEV1 FVC is less than 80%. When we talk about our oximetry, or arterial blood gases, we're really not going to see hypoxia until actually really late in the disease. The one thing we might see in a CBC is because there is this ongoing difficulty in gas exchange, you might see polycythemia, and that would be really good substantial evidence that the patient does have hypoxic levels of damage. Remember that when we're talking about chronic bronchitis, that is by definition mucus production of 3 months for 2 consecutive years, so that's going to be a clinical diagnosis. If you're following your patient on a long-term basis, though, the test that you're really going to use in your office is an FEV1. It's quick and easy to do, and it's very valuable because you can start and track and trend that patient over the progression of the diseases over years. So they're going to start having clinically significant disease when our FEV1 over FVC is less than 80%. That's how we've defined pathology. But there's other parameters that are quite useful. When they get down to 50% here, that's when you're going to start seeing the first of your hypoxia. And when they get down to 25, that's when you're going to see a oxygen level of less than 60, so that's the definition of failure. You're going to see a rising CO2, and you're going to start seeing pulmonary artery hypertension and cor pulmonale. So when you're following your FEV levels, 80% defines disease, 50% defines the first of your hypoxia, and 25% is going to define respiratory failure. So that's a really great test to use. So what's the natural history of these patients with their mixed pattern of chronic bronchitis, which is a productive cough, and emphysema, which is alveolar loss? Well, if they continue smoking, it's going to be a progressive disease. And you can follow that, as we've noted, with your FEV1. There are going to be superimposed exacerbations of acute disease. And there's reasons we're going to see that. First of all, it's a waxing and waning inflammatory disease. But remember, these are diseases that do not clear mucus. And so that mucus retention is going to lead to all kinds of superimposed changes in their normal flora. Instead of it being a relatively sterile environment, they are going to have lots of odd organisms from around the environment, which means they're always going to have an increased susceptibility to infection. And that can be both viral infections and then bronchopneumonia. So these exacerbations of acute bronchitis superimposed on the underlying chronic disease is a part and parcel of this disease natural history. As it progresses, we're going to start seeing progressive hypoxia. And And with that progressive hypoxia, we're going to start seeing cor pulmonale. So cor pulmonale from our pulmonary arterial hypertension is going to progress to right ventricular hypertrophy, which is going to go to right ventricular failure. At the level of the small airways, one of the underlying progressive mechanisms is going to be fibrosis with our bronchiolitis obliterans. And so you can see here we've defined causes of death, haven't we? We've defined death from right ventricular failure, we've defined death from bronchiolitis obliterans, and then our third risk is going to be malignancy, which we're going to see somewhere in 5 to 10% of patients. So how are you going to treat your patient? Well, obviously the first thing and the only significant important thing is they've got to stop smoking. As long as they keep smoking, that irritation is going to persist and the disease will be progressive. Treating bronchodilation is a fundamental medication help to the patient, and some of the medications you're going to see are going to be our anticholinergics. And remember, the mechanism of action here is they're going to go after the M3 receptor, which is a GQ metabolic pathway. And an example of a drug here would be our ipratropium, would be a standard anticholinergic in COPD. You can certainly use long-acting beta agonists. And remember, this is going to be our B2 receptor, which is a GS mechanism. And an example here would be our salmeterol. And then lastly, we can use theophylline. Theophylline has a complex mechanism, including immune modification, but the question we're really going to ask you metabolically, because everyone can do it, is that it causes persistent increase in cyclic AMP for pKa because it inhibits phosphodiesterase. Other drugs that we use are going to be inhaled cortisol. And that's a nice regional way of giving an anti-inflammatory. But the only thing that increases the longevity of your patient is to use supplemental oxygen. And remember that we're dealing with complex VQ mismatches, so that oxygen supplementation, you're really trying to keep it at a saturation level of around 89 to 91%. So by far and away, the largest cause of emphysema in America is going to be smoking. But there's one rare exception to that, and the rare exception to that is alpha-1 antitrypsin deficiency. And this is a surprisingly important disease because it's one of the 3 commonest lethal genetic diseases in our society. When we talk about the 3 important ones, they're going to be cystic fibrosis, they're going to be Down disease, trisomy 21, and believe it or not, we're going to include alpha-1 antitrypsin deficiency. So it's one of the big ones. If you're African American, we would also add in sickle. So it's an important disease and surprisingly common. And remember how the pathophysiology of this disease works. It is a defect in a specific protein, and that protein is a protease inhibitor. And the commonest form of the protein that we have, that's why it's called PI for protease inhibitor, the commonest we have in normal people is PIMM. There are over 200 different mutations described, but the most important and commonest one is the homozygote PIZZ. And the problem with this defect is it gives us a misfolded protein. So the protein then cannot escape the endoplasmic reticulum, and with that trapping in the endoplasmic reticulum, it forces apoptosis in the liver cell, and so the first complication of this disease is hepatitis. But the second is that you miss the protein, and so the deficiency of our serine protease, or our alpha-1 antitrypsin, is that we need it to protect it from the normal neutrophil macrophage action of its serine proteases, the most important of which is elastase. So when we can't protect our lung from elastase, that's what causes the alveolar septal loss, and so that's going to give us the lung manifestation of emphysema. So we can see from this description, and this is a bimodal disease in its presentation. Before the age of 10 years, it's going to be the manifestation at the liver. But in non-smokers in their 40s, that's where we're going to see our emphysema. So any person presenting with emphysema who's a non-smoker, or smokers presenting before age 35, you're going to directly measure your alpha-1 antitrypsin levels to make sure you're not missing one of the rare causes of genetic disease. Bronchiectasis is a disease in which there is permanent dilation of the bronchi and bronchioles from repeated episodes of infection and inflammation. Practically speaking, the only disease in which we're really going to see that is cystic fibrosis. But in fact, we can see some form of it anytime you cannot clear mucus. Because when you cannot clear mucus, you're left with that obstruction pattern of colonization of the bronchial tree, and that leads to recurrent bronchopneumonia. So when we think about how that looks, here's my normal bronchus. And when I get all that standard inflammation here, I bring in all those serine proteases of that inflammation. And those serine proteases weaken the wall, and so I get pathologic dilation, which is called ectasis, and so therefore that becomes bronchiectasis. And as the inflammation spills out into the surrounding lung tissue, I get collapse of my alveolar structure, and so all of the other bronchi end up collapsing in together into these aggregated groups. So that when one does a CT scan in our cystic fibrosis patients who are becoming short of breath, here's a transverse section, there's my vertebrae, here's my heart here, what we're going to see is we're going to see this general area in which these dilated bronchi form aggregates of these collapsed abnormal areas. And so what we're going to see in our patient from this is we're going to see this productive, persistent cough. And the great danger is that we can erode with the inflammation. And when that inflammation erodes into a vessel, we can get varying degrees of hemoptysis, which can in fact be life-threatening. So it's a disease then of persistent not clearing mucus, so we think of it predominantly as cystic fibrosis, but remember what chronic bronchitis is. Chronic bronchitis is increased mucus, but as well we're doing it in smokers, so they also get a ciliary dyskinesia. Well, that looks pretty much like we've got the same conditions as in cystic fibrosis. So you can get smaller areas of bronchiectasis in chronic bronchitis. So let's summarize what we've seen today talking about COPD and bronchiectasis. In COPD, we've talked about this as a disease of smoking across the bronchial tree. So we want to think of this as a disease of large airways with glandular hyperplasia giving lots of mucus production. And that's going to define chronic bronchitis, which is productive cough for 3 months of 2 consecutive years. We want to talk about the danger of small airways because here inflammation leads to fibrosis and bronchiolitis obliterans, which can be life-threatening. And then lastly, we want to talk about this at the level of the alveolus, which is going to be a decrease in surface area. When we talk about who our patients are, we want to talk about the emphysema end of things as a pink puffer, because that defines the pathology of septal loss is matched ventilation perfusion, so there's no cyanosis, but the decrease in surface area demands an increased ventilatory rate. And we want to compare that to chronic bronchitis, in which we get all this mucus obstruction of the bronchial tree, so it's a ventilatory defect. And so we see the blue bloaters, because with decreased ventilation and increased CO2, we're going to see desaturated blood, and cyanosis makes you look blue. And then cor pulmonale is going to lead to right ventricular failure, and that then leads to our peripheral edema. When we talk about lab testing, we're really talking about pulmonary function testing, and we want to talk about how you can follow FEV1 across the course of the disease, with definition of pathology starting at 80%, hypoxia starting at 50%, and then failure at about 25% expected FEV. We then go to what is the natural history of COPD, and we want to talk about the major ways that our patients are going to die, either from right ventricular failure from the cor pulmonale, from the bronchiolitis obliterans with its hypoxia, or from malignancy from the squamous metaplasia. And then when we talk about the treatments, obviously stopping smoking is the most important, but the only thing that's going to increase lifespan is going to be by giving supplemental oxygen. The drugs that we can use for bronchoconstriction are going to include our anticholinergics, our beta-2 agonists, and theophylline. And then after that, we're really talking about treating the exacerbations of acute bronchitis, and that's really a great role for our inhaled corticosteroids and antibiotics for underlying infection. And then the last thing we talked about today was bronchiectasis, which is defined as inflammatory destruction of the bronchi causing dilation and collapse together. And bronchiectasis then is a disease in which we see any time that we cannot clear mucus. So our model disease, therefore, is cystic fibrosis, and possible in chronic bronchitis. And that dilation and collapse of our alveolar structure then presents with a patient with a persistent cough, and these areas in which we can see these dilated structures aggregating in the lung, and the persistent infection can be difficult to treat, and then the inflammation can lead to erosion and the threat of hemoptysis, which may be massive. So that's the end of this tape. Thanks for listening. See you again soon.